Well, thank you for the kind introduction. It's great to see everyone here. It is, of course, my honor and privilege again to have the opportunity to be at the podium and present the state of the program. I don't know if I'm allowed to make the same joke twice in the same academic year or the same calendar year, but I know it was only a few months ago where I was looking for sponsorship. I'm still looking. Unfortunately, nothing changed over the holidays. Um, this lecture, unfortunately, or this Grand Rounds topic can be a little bit dry. I think it is really exciting to talk about all of the things that we've done in the program over the last year, but ultimately, a large part of this Grand Rounds is directed towards the residents so that you guys understand how we meet a lot of the accreditation requirements set forth by the ACGME. So in that sense, again, it's primarily directed towards the residents, but Grand Rounds always has a broad audience, and faculty as well as medical students. And I think none of us will escape kind of the ACGME regardless of where we go. So I hope that by the end of this, you can understand what the purpose of the survey is, and list some of the ways that our program meets these requirements. And then I think it's always good to make sure that people are aware of the wellness resources that are available through the program and through the GME office. Again, I think no Grand Rounds at Creighton would be complete without at least mentioning our Ignatian values. This is really what drives the character of a residency program. One of the things that the ACGME does is make sure that all surgical residency programs produce general surgeons, but how we do it is really left to the discretion of programs to a large extent. And we really want to incorporate all of these values in our training program. So what is the ACGME survey? If you have been a resident here, you are very familiar with the ACGME survey. You've probably heard me asking you to fill this out. Essentially, the ACGME, from a larger picture, is our accrediting body for the residency training program. This is the analogous to the LCME for medical schools that makes sure that there's the variability between different training programs is within an acceptable margin. If you were to look at how residency training for surgeons was, 50, 40, 60 years ago, it was all over the place. It was very much apprenticeship. You might learn something at one program and it would have never heard of it at another program. And so one of the benefits of having an accreditation body like this is that, regardless of what general surgery program you go to, or, for the LCME, what medical school you go to, you will achieve certain core competencies and you will come out as a general surgeon. Now, in order to do its job and fulfill that obligation for both the trainees, meaning that you can become a general surgeon, and ensure that there's trust from the public that people who we are certifying as surgeons are competent to do those things, they need to have some insight into what we're doing. So this happens in a lot of different ways. The survey is one part of it. Every fall, Jess and I sit down, we put together a lot of documents which we submit to the ACGME talking about opportunities, threats, things that have changed in the programs. We have to explain all of the faculty additions, all of the faculty changes, submit scholarly activity, make sure that everyone is appropriately credentialed to work with residents. So that's one piece of the information that we give the ACG. But in the past, they used to do more site visits, and for better or worse, they don't usually come around, but they can always choose to show up and walk the hallways, ask resident questions, see what the learning environment is like, although they rarely do that now. So the survey is a really important tool for them to hear directly from the residents about what is happening within the training program. And it really serves as a tool for early warning of potential noncompliance. This is something that they can look at the survey trends and results, and then they give us feedback as a program to say, hey, we're concerned about these areas. We think that you should really look at those and work on those as opportunities for improvement. Otherwise, there's a potential risk of losing your accreditation status. All ACGME accredited programs are required to participate. Typically happens between January and April. Each subspecialty kind of gets their own window. Ours is kind of mid-February to early April. They ask questions about the clinical and educational experiences within the program. I really, have little recollection now of what kinds of questions they ask, but I do remember some of them were kind of confusing as far as the scales go. But these are the things that they will ask you on the survey. It is anonymous and confidential, and it truly mean that. There are absolutely no individual responses that are ever shared with the program. All we get is an aggregate summary. They don't break it down by particular question. It is really kind of grouped into major content areas, which is kind of the bulk of what we'll talk about today. It does take them a few months to tabulate all of that data. So even though you'll take the survey in February, we won't get those results until May. But typically that is something that we can then incorporate into our planning for the upcoming academic year. The data from the survey, again, provides us with feedback from the residents, and it's aligned kind of with what the compliance requirements are for the ACGME. But it's also used by the surgery RRC, which is kind of the committee within the ACGME that looks specifically at surgery programs to help decide things about accreditation decisions. When they ask you questions about the survey, it's just for the current academic year. So if you're really mad at, having to take a patient to CAT scan when you were an intern, that is for that survey that already happened. This is for this year. So everything that you've experienced since July 1st, even though the year isn't over, it is still kind of a snapshot of the current academic year. In order for these kinds of surveys to be valid, we have to have a high response rate. They expect that we have at least 70% participation as a program, and as an institution, we expect that to be 100%. There's a few reasons for this. One, low participation is also a concerning sign for the ACGME. But two, we really need this data. We need this feedback. It's much like the internal survey that the GME administers early in the year. Without this feedback, we can't know kind of what our blind spots are, what our opportunities are. So we really need to know where we can direct our efforts. So this is kind of the broad overview of the content areas that they ask about on the survey. Amazingly, there is a very complicated web of how all of these pieces fit together from an accreditation standpoint. I will not bore you with all of those details, but we will kind of go through each of these sections. I won't go into great detail about everything there, but I just wanted to highlight some of these things that I think often get overlooked or can be confusing when they ask you about the survey, when they ask you on the survey, things that you are actually doing but may know by a different name. As I mentioned, these things all kind of connect to these accreditation requirements. So all of those areas, they come back on the survey. There's another document that crosswalks them to this 57-page document that tells you everything that you have to do to be an accredited general surgery residency program. I have a separate spreadsheet that has all of those broken down so that I can figure out if we're complying with all those things. And that, this is just a small snapshot of it, but it's like 341 lines. It is a lot of rules and regulations that we have to comply with. Fortunately, we have done a great job over the last 5 years. We've had continued accreditations, for more than 5 years, but this is just kind of the 5-year snapshot. Earlier in January, we received word from the ACGME that our accreditation status was continued. The ACGME is not a very verbose organization, so they will basically tell you you are accredited, or you are accredited with a citation, or if you are having a really bad year, you may not be accredited anymore. They don't really tell you if you're doing a good job, or really tell you much about if you're doing a bad job. Maybe the most you could hope for is that they might say that they commend you for your substantial compliance. We don't get any details about any potential areas for improvement. We did have some on our last letter relating primarily to the faculty survey, but we won't know about that until they generate the formal letter, which doesn't come out usually until March. But fortunately, the good news is I think that reflecting the efforts of all the residents and faculty and all of our ancillary staff, we were again able to continue with the continued accreditation status. This is kind of the big overview of our survey from last year. Again, our program has trended above the national mean, which was true the year prior as well. So the first kind of major area that they will ask you about on the survey is kind of the clinical experience and education aspect of it. A big piece of this is work hours. So I know you guys are probably sick about hearing of work hours. I am also sick of it too. I have learned more about how New Innovations works in the last year than I ever wanted to know, and I would love to forget it. But just again, pointing out a few things. So you all know about the 80-hour work week. That's familiar to residents, faculty. This is 80 hours averaged over 4 weeks. So if you worked 90 hours in 1 week and you worked 20 hours the next week, that would still average to less than 80 hours. So it doesn't mean you can't work more than 80 hours. It just has to average to less than that. Days off, again, a topic that can be very confusing. I think I have maybe after a year finally understood how this is calculated, but essentially where this 1 in 7 day off rule comes from is that you need to have 4 days off for every 28-day period. And so that's kind of this rolling average. You should not be in the hospital more than 28 consecutive hours when you're on call. So you have 24 plus 4 hours. And that last 4 hours is for not accepting any new patients, but just to transition care and for handoffs. After you do an in-house call shift of 24 hours, you do need to have adequate rest, so having 14 hours off. What kinds of things count as work hours, which includes these clinical and educational activities? It's mostly what you would think of, so seeing your patients in the morning, going to the operating room, being in clinic, those things all count as work hours, being in conference, when you're on call and actually doing work from home, when you're filling out your charts, those things all count as clinical and educational activities. What doesn't count are kind of all the other things that you need to do to be a successful surgery resident, meaning preparing for your cases the next day, studying for the ab site, which is probably the only thing that everyone is thinking about right now. So we'll make sure that you get a copy of this presentation after you're done with the ab site. Research work you do at home, non-clinical work that you're doing at home while you're on home call, for example, those things don't count as part of your work hours or your clinical or educational activities. So again, work hours, last year, as you all know, this was a big area of concern for us. We had a large number of violations, particularly early in the year. We had a big change in how we did the schedule, and the rotation dates made this a lot more confusing because we weren't doing things kind of on a strict month-to-month basis. I think we learned a lot through this process, and thanks again in large part to the faculty and residents and all of the other staff that support our residency program, we were able to really make a huge improvement in this. I have presented this graph and keep adding to it at all of the department meetings monthly, again, just because this is so important that we are making sure that we're compliant with this and making sure that you guys are getting the appropriate time off and rest, because you're going to be busy. 80 hours a week is a lot of time to work, and we need to make sure that we are staying compliant with those work hour rules. So the next kind of big area is faculty teaching and supervision. Again, I think we're really fortunate. I'm very proud of all of our faculty. I think, we have our excellent core faculty. We have an incredible cohort of contributed services faculty who are all very dedicated to education for the residents. I have been, a different place, I was at a different residency program, I was in fellowship, and I have definitely been at places where, the balance between service and education is much more lopsided. So I think that, it is really a testament to the faculty that they are really dedicated to teaching our residents. And this is something that I always tell the interviewees when they ever ask me things about, what aspects of what I think are the favorite parts of the program. So again, I do want to just thank our excellent core faculty, Dr. Castling, who joined us last year, Dr. Griffin, who joined us recently, Dr. Singh, whom we all know, as well as Dr. Sassy, who's served as our associate program director, and Dr. DeRosa again, and thank her for serving as an APD for the last year, and congratulate her as she moves on to her next career phase as a future hospice and palliative care physician at the end of this year. Again, I think that the faculty piece is really something I'm proud of, but it is something that I think we can always continue to improve. As Dr. Allerfy mentioned, for me personally, I think a big focus of mine has been improving the quality of feedback, making sure that we're giving you tools to enhance professionalism and creating a culture of professionalism, along with that academic rigor and environment of inquiry. And so faculty development is a huge piece of this. Dr. DeRosa and Dr. Castling recently went to this ACGME Developing Faculty Competencies and Assessment course, which is really great if you're interested in surgical education. But if you're not, would probably be an incredibly boring course to go to. But I think it's wonderful that they have gone to that, and I'm hoping to send more of the core faculty because they have come back with some fantastic ideas about how to improve evaluations, how the CCC works, how to give you better feedback. Again, I think many of you heard me say that sometimes you will get feedback that's like, you did a good job, you did a bad job, but this is not very helpful to you. It's not actionable. You need to know what you did well and where you can improve. And so I think that this is something that for me is really important that we continue to work on. I think that every educational experience has to be as high a quality as we can make it. The training paradigm for surgeons now is very different than it was in the past. Before, like 30 years ago, my attendings would tell me, we would just walk around the VA at night and we would find a guy with a hernia and we would fix it and we would tell the attending in the morning. Now, that may have felt great as a resident. It was really, I'm going to tell you, it wasn't good for patients. And that era, I think, is gone. So, when we do things, I think it is important that we really focus on extracting the maximum educational value out of it, because the other downside of that era is that you spent 120 hours a week in the hospital. And I think that there is a way to train surgeons without making it so inhumane that you never see your own bed for, more than a couple minutes at a time. And I think some of the older surgeons in the audience will remember those days. Fortunately, I did not live through that time, but I would say even when I trained, that needle was still in the progress of shifting. Um, Again, we've sent faculty to various courses. I've done this ACS Surgeon Says Ed course, so it's fantastic. Dr. McCall is going to go later this year. And again, I think improving the quality of feedback is really important. Dr. Castling at the department meetings has started doing quarterly education pearls, so we can really disseminate some of these things to the wider faculty, so doing like educational timeouts, establishing learning objectives before going to the operating room, how to give better feedback, doing direct observation, which again, I think it's something that we really need to focus more on, even broadly as a surgical specialty. Other specialties, I think, do a better job of watching you outside of the OR, and really that, is where we focus. Again, continuing our lineup of education-focused visiting professors, Dr. Joe Beiske will be joining us later this year. In the past, we had some excellent speakers, Dr. Terhu and Dr. Gillespie, who came and talked to us. Dr. Ranga gave us wonderful professionalism talk in a multidisciplinary setting earlier this year. And I'm sure that Dr. Beiske will be happy to answer all of your questions about EPAs and the future of surgical education. So evaluations, again, this is an area where I think we have made significant progress, but there is still opportunity for improvement. So last year we had a big concern where the evaluations weren't matching, and we really didn't have a lot of written feedback for the residents. This year, I think that the evaluation process has substantially improved. Everyone should have evaluations. I remember going through them with you guys at the portfolio reviews, but we're continuing to make sure that we can get these evaluations matched properly. Now, that said, written feedback is not the only way that you will receive evaluations. So, when you're in the operating room and someone tells you, I think you should, try this move or hold the needle driver this way, or, make an adjustment, that also counts as feedback. It's informal, but it is still a kind of feedback that you receive. If you are working and someone just doesn't speak to you at all, that would be concerning, but I hope that that's not the case. Again, I think our evaluation completion percentage has significantly improved. This is something that, again, is a real area of focus and interest for me, the program of the department. This is something that we're going to incorporate into the faculty scorecard, because I think working with a resident, educating a resident, is really a privilege. And part of that is that that teaching effort and having a resident with you is that you provide them with feedback. And so I think it is important that if you're working with residents, you do give them formal written feedback. Now, feedback is also bi-directional. As residents, you should all have the opportunity to evaluate both the rotations, the program, and the faculty. We recognize that there is obviously a power differential there, being a resident versus a faculty member. And so all of those evaluations are completely anonymous. We do not release them to the faculty immediately after they're done. We do it on a rolling basis, so every 12 to 18 months. So it really is truly as anonymous as we can make it. What I cannot help you with is if you write your name in the evaluation, or you say, well, when I was on call with so-and-so on this particular day and we did this, that I can't help you with. But other than that, it is totally anonymous. I cannot access my own evaluations. Dr. Alifai could not access his own evaluations. And we don't even know who has written them. All I can say is that they were done. Again, opportunities for improvement, and we'll continue to work on making sure that the completion rate for evaluations is high and that they're done in a timely fashion. Leaning in again on the EPA and the Simple app as a tool for you to get feedback that you can kind of carry with you over time, so that you can say that, hey, look, when I was an intern or a second year, I started as, supervision only, and now I'm a third year for this lab chole or this lab appy, and, it's passive help only or supervision only. So you can really kind of see your progress and get those comments. Again, I think we'll continue to work on making sure that the evaluation forms are more specific to your rotations. That's something that will be a project, I think, for this upcoming year. So educational content, this is kind of like the grab bag category in my mind of the survey. It encompasses a lot of things that are like very specifically called out, like mitigating sleep deprivation and fatigue. And so you may wonder, like, I don't think we had a curriculum on this, or I don't think anyone taught me about this. I can almost 100% guarantee you that you did at one point learn about it. Now, whether you remember it That's a different question. But this is the whole purpose of those GSET modules that we are always hounding you about, as well as the clear blast that you guys go through monthly with the GME office. So they have developed the full curriculum that addresses all of these things. It's longitudinal, so you won't do everything every year, but by the time you graduate, you will have received all of this education. Um, I know they're very tedious, but they do fulfill an important kind of regulatory mandate. And if it is any consolation, all of the core faculty also have to do GSET modules in addition to all of the Common Spirit modules that we do. So we do share some of the pain that you guys are going through with these. But there is a large, again, if you don't believe me, I have a very detailed spreadsheet about all the modules that you guys have taken. So I'm sure I could find whatever question there is on there. Scholarly activity, as Dr. Ellerfy mentioned, again, in addition to feedback, professionalism, I think environment of inquiry and increasing the academic rigor of the program is really an important area, and I think we continue to do well in improving this. Now, scholarly activity is something that is required, to graduate residency, but it's really, I think, fortunate that they don't define it so strictly that it means that you have to have published a journal article by the time you graduate. So scholarly activity is really broadly defined. It would be pretty hard to graduate residency without having done at least one of these things, but it includes things that you would think of, like publishing a journal article, presenting at a podium or a poster, doing quality improvement projects counts, contributing to chapters or textbooks, participating in basic science or clinical outcomes research, and then even things like giving, lectures at your sponsoring institution. So for the chief residents, when you guys give grand rounds, you're giving, a 40 to 50 minute grand rounds lecture, that counts as scholarly activity. And that's really, it's an invited presentation. You can put that on your CV. And so that, again, counts as scholarly activity. I think we as a program have a lot of opportunities for scholarly activity, which, again, reflecting on my own training experience and other residents that I've worked with, I think is not necessarily the case. And so I really do appreciate, all the resources that the department has provided to help support the residency, all the support from Dr. Ellerfy for this. We have our dedicated research curriculum, which is now in its second year. And we've taken feedback from the residents to kind of continue to hone this and make it a valuable experience for you. We have a dedicated research coordinator. There are research councils and rigs for subspecialty research areas. Of course, you all know that Dylan is on his research year right now, and we'll be finishing that up soon. And so that is always an option for anyone who's interested in that. If you have things that you want to present or you have things that are published, we will fund you to go present those things, and make accommodations for you to be able to do that. And then you can always work on quality improvement projects. Dr. Singh and Dr. Adams are our faculty and resident champions for this year. Again, I think as important as faculty development is, a large part of what we do is kind of helping residents form their professional identities. And so I think treating you guys as we would the faculty in terms of developing you as future leaders and future surgeons is really important. Last year I was really happy to be able to send, Dr. Brown and Dr. Alex, the ACS Residents as Teachers and Leaders course. This used to just be called Residents as Teachers, but I think that they recognize that, surgical residents are leaders, and this is really an important part of your future careers, regardless of whether you're in any kind of formal named leadership position. They both came back, gave a wonderful grand rounds talk. We'll be sending 2 more residents this year, and my hope is to continue that trend, indefinitely. I think it's really a great program, and really is one way that we try to invest in our residents and kind of bring that knowledge back to the program. Again, I think that we are also fortunate to have a number of visiting professors. This is, again, not always the case at various institutions, but it really helps give you insights from an external perspective, some high profile speakers. And I think, again, we have a really great lineup of speakers for this academic year. And if you guys have ideas for speakers for next year, please submit those. I think that we're always looking for ideas on who to invite. So diversity and inclusion is kind of included as one of the headings on the survey. Now, with all of the state and federal changes, this is something that the ACGME is not really going to wait in any kind of accreditation decision. So I'm not sure if they're going to ask questions about that. But I do think it is worth mentioning because it is something that is important for our program and for our department. We have made tremendous strides from the department level in terms of rural surgery. Our own Scott Reitz was really the impetus for the Rural Surgery Symposium. As Dr. Allerhard mentioned, there was a recent ACS Rural Surgery Summit. We've got our first generation medical student surgery. We try to utilize holistic applicant review during our interview process, incorporating social determinants of health and M&M. Dr. DeRosa recently helped us launch the cultural complications curriculum, which will continue through this year. We're sending a large contingent of residents and faculty to the North American Rural Surgery Society. And again, I invite any interested residents to go to the Leadership and Advocacy Summit, which we'll be happy to support. James went last year and has pictures with every major leader in surgery, and probably has a few congressmen and senators' phone numbers. So resources is the next large section on the survey. A lot of this has to do with kind of the things that are available to you, like in the hospital, to support the work that you do. One that I wanted to specifically call out is this area of non-physician obligations. And what does this mean? Sometimes I think that, what is a physician's roles can be kind of nebulous and a little bit variable. But essentially what this means is that things that are typically performed by non-physicians, so like nursing staff or, allied health professionals, so like, the physical therapist or the occupational therapist, those are things that are generally considered non-physician obligations. That doesn't mean that you may not ever do them. So like, if a patient needs help getting out of bed and you help them get out of bed, that doesn't mean that, you are performing non-physician obligations. You kind of are, but not really. It's where it becomes an issue is if you're doing it routinely. So if you're having to get up in the morning, you round on your patients, and then you also have to draw the blood on all of your patients, and you have to do this every day, that would be a non-physician obligation that is not kind of within the scope of your training or your role. Now that's a little bit different than, 3 nurses tried, they couldn't get blood on this patient. Now you come in with an ultrasound or you get an arterial stick, that, would not count kind of as a non-physician obligation because you're not doing it routinely and it was something that, needed your particular skills. Again, didactics is really, I think, part of the culture of inquiry. It's part of the learning environment. I think that didactics has been something that, looking at this program compared to, again, other places I've been, I think there's a large amount of protected time for didactics, which is great. I think that the resident involvement in didactics is really commendable. This is really, since I've been here, something that the residents have largely driven. You have your protected time each Wednesday. Of course, there have been some growing pains with the shift from didactics from Friday to Wednesday, but I think we're continuing to adjust. And ultimately, I think that as with all change, we will eventually get through it and figure out how to make it as best an experience as possible. We utilize the national score curriculum. You have access to the True Learn question bank, based on feedback from the residents. We also purchased the AppSite Quest. We continue to do mock orals twice a year, jointly with UNMC. Last year, we had we had offered for the chief residents to attend this ACS virtual mock oral course, which is really excellent. Unfortunately, the ACS is no longer offering that course, but we have partnered with Caliber this year. And so far, I've heard that feedback has been positive. And I think that, if that trend continues, that's something that we'll try to offer additional sessions for, particularly for the senior residents as they approach their board exams. I think an opportunity for improvement is getting more faculty involved in didactics. I think we did a better job of this last year. I think early this year, this kind of fell off, but we're really emphasizing this again. And the faculty are very interested and they want to participate in didactics. And so this is something that we're going to focus on for the last half of this academic year and then really hone in on for the upcoming academic year. And again, going back to, faculty accountability, completing evaluations, participating in things like didactics and serving as subject matter experts, I think will be, another area of focus. Again, investing in the residents as we would our faculty. I think the PEARLS program, I think Dr. Singh for relaunching it this year, is something that we are continuing to, work on and revise, and, we welcome your feedback. I think we've had some excellent speakers so far, and really the goal will be to make this a truly longitudinal curriculum so that almost by the time you graduate, you've received a kind of mini MBA as a resident. So you really go out into the professional workforce incredibly well prepared for the professional aspects of your career. So simulation, they ask about this on the survey, I have no doubt. This does not necessarily mean that you are in a sim lab, with someone like watching you and then doing a debrief. The skills labs that you do, these things count as simulation, even though they kind of feel like low fidelity simulation. This is an aspect of simulation. So when you're doing like the airway lab with Dr. Reisbeck, that counts as a simulation activity. When you're doing your bowel anastomosis, vascular anastomosis labs, those things all count. I would say that this is, again, an opportunity that we're going to continue to work on improving. After, I've been here 4 years, and kind of with the program as in a leadership position for, 2 or 3 years-ish. And we finally have gotten access for the residents for this third floor simulation space. It was incredibly difficult for something that should have been incredibly easy, but it is there now. There is a robotic simulator there, and I think more importantly, there is an endoscopic simulator there, which is the same one that you would use when you take the FES exam. So it's kind of one-to-one as far as practice goes. My hope is that we will be able to become an FES testing center as well. So we've kind of started the process with that. But as with, all of these things, it does take a little bit of time to get that going. Unfortunately, this year, cadaver availability has been an issue, but we really are going to continue to look at how we can get cadaver so we can do another cadaver lab and put on another asset course as well and try to make that something that is yearly. We're going to look at kind of really honing in on the simulation and skills curriculum. So open skills, laparoscopic skills, robotic skills, and then aligning this with the things that you have to do to be ready to sit for your board exam. So for example, coming in, as an intern, you'll do your lab skills, and then it will end with you taking the FLS exam. You'll do your endoscopic practice, and then you'll end with it with your FES exam. That way you're not scrambling kind of at the end of the year when you're trying to apply for your board exams, and it's done. And then also, when you go into the operating room, you can confidently tell your attending, yes, I've done all the modules. I'm ready to, do X, Y, or Z for this case. This is kind of the third learning objective. And again, this is something that they will mention on the survey, that you have access to these kinds of resources for counseling. I do think that the GME office here does a good job of putting these together for you. I'm sure you guys, I would be shocked if no one is not aware of Dr. Harlow. I think I told like every resident that they should probably go see her. I wish I could go see her. I think that it is an incredible resource. I wish we had something like this in residency, but she is kind of the wellness component for the GME office. What is really advantageous for her is that she is part of the GME, so she understands what residents do, and she knows kind of what your experience is like, and she knows how the GME works, but she is kind of Switzerland. So, when a resident goes to see her, that information doesn't come back to the GME, it doesn't come back to the program. She is there to be your advocate. You can tell her whatever you want. And if she thinks that it would be helpful, to share information, then she will talk to you about it. And that is a decision that you guys can make together. But I think that this is a great resource that I encourage everyone to take advantage of. In addition to that, if for some reason you feel uncomfortable even, using any resource within the GME office, there are a number of other options available to you. And many of these are also applicable to the faculty as well. So LifeBridge Nebraska, they offer physician-to-physician peer coaching that's available to any licensed physician in the state of Nebraska, which includes all of U.S. residents, includes faculty members. As house staff, part of your contract, much like, Common Spirit or CHI employees, you have an employee assistance program that's available to you. They offer things like telehealth, telepsychiatry, as well as crisis management and counseling. The Metro Omaha Medical Society also offers telepsychiatry and teletherapy services. And so there are a number of resources available to you to utilize, kind of for wellness, or if you're having concerns or, feeling burnout or anything like that. In addition to that, Sebastian has been our wellness chief this year. I know that you guys have done a few events so far, and I encourage you to continue to do that. One of the things that I am most proud of the program is kind of the sense of camaraderie that the residents have. I can take no credit for that, but I am happy that it's there. It's one of the things that I tell the applicants is my favorite feature of the program. Some programs become incredibly impersonal. I graduated with, 11 chiefs, which is a huge program, but I think that you guys are very tight-knit. And I think that really reflects in the caliber and quality of the program. Those are things that we support through the department. We're happy to fund those activities for you guys to get out of the hospital and be together. Safety and health conditions. Again, this kind of refers to some of the physical infrastructure stuff in the hospital. I know that the call room spaces have been like this ongoing thing. It is not something that has been forgotten about, but it is something that much like access to the third floor simulation space has taken some time to really get traction on. That being said, I think we finally were able to get the carpet changed in the resident workroom, which thank you all for moving the furniture and making that happen. But at least we were able to do that. That said, as far as the call room spaces and other common areas, the GME is aware of it. They've done like 12 walkthroughs, so they are acutely aware, and they are continuing to kind of leverage whatever pressure they can apply to improve those things. There is, of course, any confidential reporting available. So if you do have concerns and you don't feel comfortable bringing that, to a faculty member or to me or to someone else in the GME office, you can always scan this code, goes to the Creighton website. You can submit these anonymously, goes directly to the DIO who can then address it. Patient safety and teamwork is another big area on the survey. I promise that we are getting kind of close to the end here. I know this is not the most exciting thing that we talk about this year. Information not lost during shift changes, patient transfer handoff process. I think that the majority of services now are utilizing the Epic handoff tool, which I think has been very helpful. Previously this had actually won as one of the QI projects, that standardized handoff tool that was used. I know that it's been a dramatic change, at least on the trauma service, going from these printed lists with a lot of handwriting on it and a lot of tedious work, now to a list that you can print and actually just have the pertinent details on, and be able to update throughout the day and have better handoffs. I hope that everyone knows how to report patient safety events, or you have at least heard of the IRIS system. I promise you can enter an IRIS. You just have to log into a CHI computer. It will be on the desktop. It is, I will admit, kind of tedious to fill out an IRIS report, but that being said, it can feel very unsatisfying to fill one out, but they do get attention. They are looked at. So anytime you fill out an IRIS report, it goes to someone that is in senior leadership, and then they do address it. You will often get a reply back, a few weeks later that says like this was closed or we addressed it. And you don't know what they did, which can again be unsatisfying, but for various reasons, that's kind of how that process works. But I promise that they are taken very seriously. So it is a good mechanism if there is any patient safety issue that you observe. There's also a phone number that I will share with you guys by email that you can even leave a voicemail message if you don't want to go through filling out this form on the computer. Interprofessional teamwork skills modeled or taught. So, again, I think this is a strength. You guys do this all the time. You may not realize it, but you're always working multidisciplinary teams. So when you're rounding and you talk to the nurses, or they tell you, this is going on with the patient, and you guys make a decision together about what to do next, that is multidisciplinary collaboration. You participate in multidisciplinary rounds, on the trauma service, the noon conference, with physical therapy, speech is there. When you round with the pharmacist in the ICU, these are all examples of multidisciplinary rounds. So this is the stuff that you guys are doing every day. I think it's inescapable. There's no, unidisciplinary surgery. Participation in safety event investigation analysis. So, I think we have utilize our quarterly quality and safety grand rounds. So this is kind of when you get practice data back. You hear about what the SSI rate is in the hospital. When I send you guys the hand hygiene reports, these are examples of kind of quality feedback that you get. In addition, the ACGME wants residents to understand how to participate in things like root cause analysis. So RCAs, this is the same as an EIA or an event investigation analysis, just slightly different terminology. So it's not to say that you have personally participated in one of these, because hopefully there are not so many patient safety events that you have all participated in RCAs, but merely that if one happens, you have the opportunity to participate one. The GME office has done a lot of work with Common Spirit to make sure that residents can participate in these, and they do keep track of this. In addition, several residents serve on quality and safe quality committees on the hospital, and you guys are all welcome and encouraged to join those types of committees. I know that a couple of you are on the Surgery Advisory Council. Residents have served on the Opioid Stewardship Committee in the past, so there are opportunities to also participate in the hospital's quality and safety process. Professionalism, lots of questions about this. Again, these are the things you observe. Along with feedback, professionalism has been a real focus. I think Dr. Ranga gave a really nice House of Surgery, grand rounds in the fall, with the anesthesia and operating room staff here, kind of around professional identity formation and how to, behave in the workplace. My hope is that, you feel comfortable calling your senior residents, your faculty with any questions or concerns. And if you're not, then please let me know, because that is something that we want to make sure that those lines of communication are open and that people feel safe and able to discuss things in a clear and open fashion. That said, if you do have concerns, there are a number of ways that you can raise these concerns. So, ultimately, one of the section of the survey is one way that you can voice these concerns. But before it gets to that, hopefully you'll be able to utilize one of these mechanisms so that we can make some actionable change kind of in real time. As a junior resident, you can talk to your senior residents. As a senior resident, you can talk to the faculty on your rotation. You can talk to any of the core faculty, non-core faculty, talk to your associate program directors. You can talk to me, you can call the chair. So there are options available to you. We really do try to make ourselves available for feedback, questions, concerns, things like that. You can always reach out to the DIO or any of the GME staff, and they could help you, find the right resource to point you in the right direction or try to address your concern. The PEC committee is also another way that you can kind of report concerns, and we can work together on developing action plans to make those things, to create improvements in those areas. Of course, the GME internal survey is important. You've heard me say this, like it's really important that we get this feedback from you guys. And then there is also anonymous reporting, through that QR code I shared earlier, and that goes directly to the DIO. It's not shared with the programs, so there are mechanisms, like should you have an issue like with the program itself, you can address that outside of kind of the program leadership. Again, I just want to say that I do think that sometimes it feels like, you may say things and nothing gets changed, but we do really take the feedback seriously. I do think, I hear a lot of feedback. Unfortunately, sometimes the reality is that we cannot always, pivot and make things change right away. But, everyone should be heard, and I hope that you feel that you have a voice. I think, with any surgery program, we have to make sure that we're doing surgery. So as you guys are all aware, the ACGME has case log requirements. You need to do 850 total majors, 200 cases in your chief year, and then there are a number of subspecialty cases that you need to get. We have a number of excellent clinical partners in the community. Fortunately, we're kind of well into our transition to pediatric surgery at Children's Nebraska, which has been, I think, a very positive experience for the residents. We have good long-standing relationships with transplant surgery at UNMC, burn surgery down in Lincoln, and then head and neck at Nebraska Methodist. I think that that's a very unique rotation. It's not something that you will find in a vast majority of general surgery programs. And so I think it's really wonderful that we do have that available to you guys. As always, there's some variability in surgical volumes. Overall, we clearly exceed the minimum requirements. There is a little bit of variability in some of this math because of the way that the things were calculated with some off-cycle residents, but overall we continue to meet our minimal surgical volumes. I think that there are already kind of uncovered cases within the system. I think that there will be more surgical volume being generated. We have had some changes in staff, but recruitment has been ongoing, and we have a number of new surgeons that we have welcomed to the system. Our vascular group has become very busy. We have a new plastic surgeon. There's active recruitment for a new colorectal surgeon in chief, new general surgeon at Lakeside. We have 3 thoracic surgeons now, 3 cardiac surgeons. We have a new trauma surgeon. So there's going to be tremendous growth, I think, in this area, and just even more opportunities for you guys to be involved in cases. That said, we do pay attention to subspecialty case numbers. So I know that is a concern. That's something that I talk about with Dr. Alfai every week. As much as he may get tired of hearing about it, but it is really important. We do take it seriously. So that is always on our minds as we look at these things. So we'll almost close to getting wrapped up here. The last 2 slides are kind of just talking about some peculiarities of the survey. So the ACGME is this kind of stoic regulatory body. Their surveys are a little bit different than other surveys you may take, in the sense that neutral answers are not neutral. Neutral is bad for the ACGME. So generally speaking, only kind of the top 2 box answers are ones that they consider compliant. Sometimes the scale flips. So I think you need to be honest on the survey. You should reflect your experience in the residency program. But please read the question and read the scales, because you do want to make sure you're actually telling them what you feel, and not kind of the opposite just because the scale flipped. Here's kind of a table of synonyms. I haven't really found a better way to break down what these actually mean. But somewhere in here, I think you should be able to figure out, I think, an answer to the question. They may say assignment on the survey. That just means rotation. Again, these are just kind of some example scales. Things that are, in red would potentially be considered non-compliant. So again, neutral answers for the ACGME are not neutral. That's considered a potentially non-compliant response. So just summarizing, hopefully you guys understand the purpose of the survey. It gives the program feedback. It gives the ACGME feedback about what the residency program is doing and if there are any areas of concern for early warning. Hopefully you've gotten a sense of kind of the ways that we meet these requirements. As after you have taken the app site and you're now trying to take the survey, if you are wondering, how we meet, compliance with a certain area, feel free to ask. We'd be happy to, help you figure out, if we do that. And, sometimes if we don't, then that's also something we'll need to look at. And again, I encourage you all to utilize the wellness resources that are available through the GME office. So just, again, a few final thoughts. Really, I think that, things continue to change, but the department and the program are still very strongly aligned and committed to training outstanding surgical residents. I'm proud of all of the residents here, and I think that you guys are going to be great surgeons. And I hope that we can, make you very strong surgeons in the future. There are, of course, changes every year, but along with these changes, there are opportunities for growth. Really, I hope that you recognize that I think the future is bright. That's my personal belief. But that you also have a stake and a voice. This is your residency program. Not everything can change and not everything should change, but I do want to make sure that you all feel like you do have a voice and that your feedback is taken seriously. And I want to say that that's true for both the residents as well as the faculty. With that, thank you, and I will try to answer any questions you have.